Okay, sounds great. I'm a improvement advisor for HQI. I actually worked on the last MRSA project with Brenna quite a bit over the last year and a half, which was really exciting. So I'm excited to take the experience here. I've been with HQI for almost 10 years now. So lots of different improvement activities over the years, but truly excited to work with you all.
I'm Catherine Zapik. I'm a senior consulting manager here at HQI, so I'll be providing leadership support to this project, but I'm happy to have both Jeanette and Jeff working with me as they have been implementation advisors in the past on previous work, as Jeff mentioned, so I'm happy to be here. Jeanette?
Thank you, Catherine. I'm Jeanette O'Neill Gonzalez. I have worked with Brenna before in our project for MRSA as well. I do have federal government experience managing and covering grants. So I'm very excited to be part of this opportunity. So thank you very much.
Okay. I'd like to turn to our colleagues from HSAG.
Oh, hi, this is Padma Tagarsi. I'm the lead on this project, and I've also helped with the MRSA safety project and antibiotic safety project in ambulatory care. And Madhu?
Hi, I'm Madhu Mukundan. I'm the health informatics specialist here at HSAG. I've worked on a couple of implementation, several federal quality initiatives for physician office and nursing home.
Hi, I'm Una Fraser, and I've worked on quite a few of the AHRQ projects, and I will be providing administrative support.
Thank you. Glad to have you guys here today. And then I want to turn to Stratus.
I can start. Hi, everyone. Kelly O'Neill with Stratus Health. And I'm here today with my colleagues, Christy and Lisa. And Stratus Health has worked on a number of these projects, providing implementation advisor support. And happy to be back on this one. Christy, I know you've worked on several. Why don't you go next?
Okay, thanks. So yes, I'm Christy Fable. I'm also an implementation advisor from Stratus Health. And yes, I've worked on several of these AHRQ safety programs. So glad to get this one started. And next would be Lisa.
I think you're on mute, Lisa.
You might be double muted, Lisa.
Can you hear me now?
Yes.
Sorry about that. So sorry, I'm Lisa. I'm new to Stratus Health. I've been here for about a month. So I'm learning about all these quality initiatives and programs. I'm just very excited to be here.
Thanks. It's great to have you guys here today. I wanted to turn now to our national program team, starting with the Johns Hopkins folks.
Yeah, I can start. My name is Sarah Keller. I'm an infectious diseases physician at Johns Hopkins, and will be leading the webinars and other things, along with my colleague, Dr. Pranita Tama, who will be joining in a little bit.
Hi, I'm Novel Yu. I'm the program coordinator for the Johns Hopkins Armstrong Institute, helping on this project.
Thank you, guys. And now I want to turn to the NORC folks on the call today. Why don't we start with you, Carly, Priscilla, Roy, and then move on to Ashley, Heather. Gosh, now I'm getting lost. All the faces, the heads keep moving on my screen. Sorry. And then Michaela and Karen.
Great, thanks. Well, it's great to have you all here. We're so excited to be having this Train the Trainer meeting today and be getting moving. I'm Carly Perry. I'm a vice president at NORC and the implementation and recruitment lead for this safety program. And Priscilla?
Hi, everyone. It's actually so nice to see so many familiar faces, and I know we've journeyed along on many patient safety projects, so thrilled to have you here. Clearly, you must like us because you still join us, so happy to have you all here. I think many of you know me, but for some of the newer folks, I'm a vice president and fellow at NORC, and I direct NORC's Health Implementation Science Center. And for the purposes of this project, have been working very closely with the rest of the NORC team, the Hopkins team, and AHRQ in the role of a senior advisor. And looking forward to the implementation meeting today and supporting you all as we get underway. Thank you.
Hi, everyone. Good to see you again. Roy On. I'm a vice president here at NORC and really helping the data collection and analysis team. So looking forward to working with you all again.
Hi, I'm Ashley Anderson. For those of you who don't know me, I'm a research scientist at NORC, and I've had the pleasure of working with quite a few of you on the AHRQ Safety Program for MRSA prevention. And so I'm really excited that we're now launching this one and that I'll be able to work alongside you again. So great to see you today.
Hi, everyone. I'm Heather Hussey. I'm also a research scientist here at NORC, and I will be working closely with Roy on the evaluation team.
Hi, everyone. My name is Michaela Harmson. I'm a senior research associate at NORC, and I will be supporting implementation and assessment, including the website. So I'll be sure to be interacting with you guys and look forward to working together.
Hello, I'm Karen Correa, a senior research associate also at NORC. And yeah, I've been supporting recruitment and will be also supporting the implementation. So excited to work with everyone. I think Fiona, you may be our last NORC member.
Yes, Fiona, please introduce yourself.
Hello, yes, I'm Fiona Grady. I'm a research associate at NORC. I have helped on the MRSA prevention project, and on this project, I've been supporting recruitment, and I will be supporting implementation as well.
Okay. Thank you, everyone. And we also have Melissa Miller from AHRQ, who is our sponsor and funder for this work. The team at AHRQ has conceptualized this and is providing this support for this. And so, Melissa, I wanted to turn it over to you to give a couple of opening remarks before we dive into the meeting.
That sounds great. Thank you so much. As Allison said, my name is Melissa Miller. I'm a medical officer here at AHRQ and the Division of Healthcare Associated Infections. And I'm a senior advisor and subject matter expert on this project. I am also the core for the MRSA project and was for the antibiotic stewardship project. And so I just want to thank the many of you who reported your work on those projects as well. Standing in today for Susan Henderson, who is the contracting officer's representative for this project and lead for AHRQ. She's so sorry she can't make it. She is actually on leave and did not want to delay the work going forward. So I just want to say that we are so thankful for your participation today and really look forward to your input. Your organizations and you in particular have all had such really valuable input in the past on our work and advice for interventions. And we really look forward to your input. We're also very excited to share the progress and work that has been going on to this point. The practices that we have enrolled and are really excited to share the plans going forward. So I will hand it back over to the project team and thank you again for your participation. Unfortunately, I cannot stay, but we'll look forward to looking at the minutes of this meeting and learning from all of your input. Thank you so much.
Thank you, Melissa. Okay, and now before I'm going to briefly cover the objectives of the meeting before I turn it over to the rest of the team, but before we dive into that, I wanted to just briefly let everyone know that we are planning to record the meeting today. We're doing this so that as folks perhaps come onto the project later, they're able to refer to this back as a resource. I think the team already started the recording, but we'll be continuing that as long as there are no objections, and it will serve as a resource for you guys after this meeting today. Okay. All right. I'm also learning my new Zoom where I can toggle between screens, so I'm a little slow today as I'm learning how it works. So I'm looking at the meeting objectives now. You can see what we want to cover today. We will provide an overview of the safety program for antibiotic use, update the group on recruitment. Our recruitment period is scheduled to close pretty soon, and we'll provide an update on where we stand as of today. Introduce the planned program educational content, explain the roles and responsibilities of the implementation advisors during practice onboarding and throughout implementation period. Introduce the participant data collection requirements and process, and then provide an overview of the program website and portal. So now we're done with sort of the introductions. I'm going to turn it over to Carly Perry, who's going to talk about the overarching goals of the program.
Great. Thanks so much, Allison. So if we move to the next slide, we'll start talking about some of the background here about improved antibiotic use in telemedicine, as you all know, promotes patient safety. So this program was developed to address the need to reduce inappropriate antibiotic prescribing in the era of telemedicine. And telemedicine use, as you all know, greatly increased during the COVID-19 pandemic. In the US, organisms that are antibiotic resistant cause 2 million infections per year and 35,000 deaths per year. Side effects from antibiotics prescribed in ambulatory care lead to 150,000 emergency department visits annually. So judicious use of antibiotics is especially important in the telemedicine environment, as infection-related complaints make up a large portion of telemedicine visits. And as noted in the final bullet, 2/3 of visits for upper respiratory infections inappropriately result in an antibiotic prescription. Moreover, we know that unnecessary and overly broad antibiotic use directly contributes to antibiotic resistance and makes future infections more difficult to treat. Improving appropriate antibiotic use requires addressing multiple barriers, and this program will address many of those barriers. Those include time pressure, inability to perform a physical exam, and lack of access to diagnostic testing. The program is also going to address some issues surrounding patient satisfaction and communication, especially with respect to perceived patient desire for antibiotics and perhaps a lack of understanding of the potential negative consequences of antibiotics. And I think many of you who've been in clinical context are aware of some of these challenges. Next slide, please. So AHRQ previously funded the development of antibiotic stewardship toolkits, some of you were involved with those, for the acute care, long-term care, and ambulatory care settings. Each toolkit was delivered over a year-long period with 402 acute care hospital units, 439 long-term care facilities, and 389 ambulatory clinics participating in these prior cohorts. The 3 previous safety programs contributed to statistically significant reductions in antibiotic use and improvements in antibiotic use, in inappropriate antibiotic use rather. In the program that was focused on antibiotic stewardship in ambulatory practices, participating practices saw a 9% decrease in antibiotic prescribing overall and a 15% decrease for acute respiratory infections or RTIs. In addition, pediatric practices saw an 11% decrease in antibiotic prescribing and a 13% decrease for RTIs. And we, of course, hope to see similar improvements during this program. Next slide, please. This slide touches on some of the goals of the safety program for telemedicine in particular. So at a high level, the current program has 4 primary goals, which you can see in these 4 tiles here. If you look at the upper left, first, it aims to identify best practices in implementing antibiotic stewardship in the context of patients seen via telemedicine. If you look to the upper right, it's seeking to adapt the CUSP approach, which is a team-based quality improvement method, to help practices enhance their antibiotic stewardship in telemedicine. We'll provide an introduction to the CUSP approach later in this meeting. As you look at the bottom 2 tiles on the lower left, the program will implement and evaluate this approach across a national cohort of practices And these are virtual first telemedicine practices and brick and mortar, so they're both. And on the bottom right, the ultimate objective of the program is to positively influence antibiotic prescribing to reduce inappropriate antibiotic use. So by instituting this program, we're hoping to first promote improved telemedicine workflows in eligible practices and enhance teamwork and communication, and also improve patient safety and safety culture overall. So there's some more micro and more macro level goals. Next slide, please. So we'll take a moment here to discuss what's meant by a practice in the context of this initiative, because it's a little bit unique compared to some of our prior ones. In our pre-recruitment and our recruitment efforts, we've been having conversations with telemedicine organizations and our technical expert panel members, and we've learned that workflows and teams are structured very differently in facility-based versus virtual-only organizations. And you're probably aware of some of the diversity of approaches and structures that these organizations use to deploy care. The concept of a team or team-based care may not apply in the same ways in virtual-only organizations, where many providers practice independently, sometimes from their own homes, sometimes they're contractors, sometimes they're employees. They may not be regularly interacting with other providers or even schedulers or staff. We've had a number of conversations with companies that have corroborated this, and this has shaped some of the way that we're thinking about this and defining a practice. And therefore, for purposes of this program, we're defining a practice differently for facility-based and virtual-only organizations. For the facility-based organizations, if you look at the graphic on the bottom left, a practice is operationalized as a physical clinical site that provides care. For virtual-only organizations or organizations that don't have a physical location, we have defined a practice as an individual clinician who delivers care. And this accounts for the fact that individual providers may not regularly work as a team. We want to emphasize that these definitions will not impact how participants will engage with the program. Everybody, regardless of how they deliver care, will have access to all of the educational content, the office hours, and the support from IAs. This is a way of defining a practice. It has affected recruitment, what's affected assignments, the IA organizations. We'll be talking about that a little bit later as we talk about how assignments are going to be made. Let me just stop there and see if there are any questions about this before we go further. If you have a brewing question, you'll have another chance to come back to this as we think about how it's operationalized throughout. Okay, let's go to the next slide, please. This slide will go over the program timeline. So at a high level, this is an 18-month quality improvement program that will engage eligible practices to improve appropriate antibiotic use in telemedicine. The program entails multiple activities, many of which are concurrent, as depicted in the timeline on the slide. You can see the implementation and data collection happen concurrently. Recruitment officially kicked off in January 2024. We began pre-recruitment in the fall of 2023 with a goal of recruiting 300 to 500 telemedicine practices to join the program. And today is actually the last day of the recruitment period. So things are flying in because it's the enrollment deadline, and we know that people like to wait till the last minute, but we've already had very, very robust response to this initiative, and we'll discuss that subsequently. We're really delighted by the response that we've had. In consultation with AHRQ, we will determine shortly whether the recruitment deadline will be extended, and if so, to what date. But I should let you know that we do plan to allow sites that have active applications as of this date today to proceed to the LOC stage. That's the letter of commitment. There's a limited number of those. And as with past cohorts, we anticipate some practices will start after June 1, but they wouldn't start any later than July 31st. So I'll also mention that simultaneously with recruitment, we've been developing the program education materials. Our team has been working on this very assiduously for months, and the program's 18-month implementation period will begin in June and conclude in late November 2025. As I alluded to before, the data collection for the evaluation will run concurrently with the implementation period. Next slide, please. So this slide gets in some of the specifics of the program structure. Broadly, there are 6 main ways in which practices can learn and engage with the program, and I'll provide a high-level overview of each of these on the next couple of slides, and then we'll go through these in more detail throughout today's training. Starting from the left of the 6 training and engagement channels, you see there are webinars, there are resources that are available to folks, office hours, monthly site check-ins, help desk, and then we have a host of data collection activities, and training and technical assistance span across these. On the next slide, we'll touch base on the first 3 of those, the webinars, the additional resources, and the office hours. In terms of educational webinars, these are the primary channel through which the participating sites will learn the clinical and adaptive educational content. And we're going to discuss the topics of those in further detail in the next session. But there are 18 of these. They're approximately twice a month. The live ones are twice a month, and then they're also offered asynchronously, but they'll be offered twice of each distinct seminar. Participants will have access to additional learning materials like one-pagers and discussion guides that can help them supplement, reinforce, and apply what they learned during the webinars. And additionally, participants have the option to attend office hours with members of the national program team. The office hours serve as an informal forum to ask questions of the subject matter experts and also as a way to learn from the experience of other participants. So there's a function here of peer learning in that, as well as being able to get their questions answered directly from our experts and our clinical leaders for the program. Next slide, please. So the next slide talks about the 3 remaining channels on here. Each site is assigned an implementation advisor or an IA who will meet with them monthly for a check-in. And this is a form of direct individualized support for the practices. The implementation advisors can help practices brainstorm how to implement guidelines, guidance, and protocols, address any challenges that emerge, answer questions about the content, and also get help with data collection and entry. The program also has a help desk, and this is a dedicated email address that participants can email with questions and that we can use to send out any helpful materials or guidance if we want to blast something out or share it with everyone. We respond to this continuously, and we assign and triage questions to the appropriate team members, whether it's our clinical expertise or our operational questions as we come to this part of the team. Finally, practices will engage in the program through data collection, and we're going to discuss data collection in detail later in today's meeting, and you'll get a chance to ask a lot of the questions you have about this. But together, these channels mean that practices have ongoing access to technical assistance and training, even between the monthly webinars. And we're using a variety of means, you're noticing, to accommodate different preferences and availability. So there's peer and group, there's more individualized contacts, there's synchronous and asynchronous ways that people can access the material. Next slide, please. Now we're going to give you a little update on recruitment. And as we move to the next slide, you'll remember that I mentioned that our goal for recruitment is 300 to 500 primary and urgent care practices that are covering all Department of Human Health and Service regions, so all 10 regions. These practices can include facility-associated practices, meaning they have a brick and mortar location, as I mentioned earlier, where they see patients in addition to their telemedicine offering, or they can be virtual-only practices that don't offer in-office care. And while recruitment officially opened to the public in January, as I mentioned, we began informally recruiting among major health systems and telemedicine organizations last fall, shortly after the first TEP meeting. So we started this early and have pushed hard on it. And recruitment officially concludes today, May 23rd. But as mentioned, we may extend the recruitment date. And if so, we'll keep you apprised of that decision if that happens. And as I mentioned, we're also accepting commitment forms after that deadline. The next slide goes over the eligibility criteria. So the eligibility criteria for the program are organized into 4 areas that you see in the left-hand column of this table. In terms of practice type, the program includes adult, family, and pediatric primary care, community-based health clinics, urgent care clinics, student health clinics, and outpatient specialty clinics that provide primary care. We exclude outpatient specialty clinics that don't provide primary care, such as ambulatory surgery centers. In terms of facility type, as we've mentioned a few times, this includes both brick and mortar practices that deliver some care via telemedicine, as well as practices that provide care exclusively via telemedicine. And we've sought to enroll facilities in all of the geographies across these 10 regions to get good distribution there. In terms of telemedicine, the way that we have operationalized that criterion is that practices must offer telemedicine with video conferencing. And video conferencing doesn't need to be used for every telemedicine visit, and we understand that some may be conducted via phone. We also understand that sometimes telemedicine visits get converted to telephone if the video isn't working properly or there's some challenges with accessing or using the technology, but it does need to be available. And in terms of technology, the program requires practices to have electronic health records, as these are needed for the data collection efforts. Next slide talks a bit about our recruitment strategies. So our recruitment strategy has relied on several groups of partners and key communication channels. The goal is to leverage contact channels that could reach different audiences with tailored messaging to ensure that we were recruiting from as wide a net as possible. So we've been promoting the program via these channels that are represented in the tiles here, these 7 channels. So first, promotion via the national program team and our TEP members. They've been really helpful and essential in getting the word out and getting people to join, making connections for us, giving us names to contact directly. And then we've also engaged with professional organizations who broadly blasted out to their listservs and their membership and gotten people involved. We've been able to show up at some of their organizational meetings and promote the program. And then we've used a direct outreach strategy, both to healthcare systems and to telemedicine organizations. And this has been quite effective. We've reached out to a number of the larger healthcare organizations, academic ones, FQHCs, community health centers, and had one-on-one conversations, help people understand the program. And this outreach to the telemedicine organizations is really essential, I think, for us to understand more about the wide variance in the structures of these organizations, what kind of messaging would be interesting and compelling to them, and to get some of them on board. Finally, our federal partners have done a lot of promotion for us. We've had a lot of presence at professional meetings and conferences for our team, sending our national program team going out to conferences and doing that work for us, our federal partners doing it. And we've hosted a series of informational webinars. So our outreach has also engaged prior participants from the ambulatory cohort of CUSP for antibiotic stewardship. And we've hosted additional group-specific webinars by invitation and numerous calls with organizations that express interest and were seeking additional information. Those calls have generally involved one to understand what we're doing, and then calls often with their data or IT specialists so they can understand the data collection requirements in more detail. The pitch points that we've developed in our communication and outreach strategy were tailored and refined by the feedback that was provided by TEP members and the first meeting and the conversations that we've had with many of you. So I'll mention our recruitment strategy used these approaches to achieve success. The success that we've had really robust response to this. We've been emphasizing the value proposition of the program with the pitch points that were developed to engage sites and enable interested parties to also pitch that program back to their leadership as well. And in terms of key points, we've talked about transparent communication about potential benefits, expectations. We've been very transparent about the time and data submission requirements. We've talked about the flexibility of the program, that there are multiple avenues for asking questions, getting information, for getting the educational content from the webinars, both synchronously and live. We have talked about, we've put program prompts into the application, which we call an enrollment form that helps practices confirm eligibility. And we've stressed the credentialing and the ability to get mock CMEs and CEUs. And I saw that we had a question that popped up in the chat while I was chatting here. And Kelly had asked, can you remind me, is the list of TEP members available? And perhaps Allison, you can answer that in the background as we move on a little bit here. Okay, next slide, please. In terms of recruitment materials and webinars, this slide provides a little detail on our outreach materials, website, webinars. We've distributed a program flyer and blurbs, newsletters, email, listserv blasts, social media posts. We've had about 215 partners who've promoted the program at national, regional, and state levels. And we really appreciate the efforts that your organizations have made, both to help us understand messaging and to promote the program to your networks. It's been really helpful and essential to us getting the kind of response we've had. Additionally, we stood up a public-facing website, which went live in December 2023, and that website serves as a hub of information for the program, and it links to the program enrollment form, so folks can learn about the program and directly enroll right there. We've also hosted 13 recruitment webinars. These have been led by Dr. Keller and Dr. Tama from JHU, Johns Hopkins University, and provided an opportunity for interested individuals to ask questions about the program. We initially had 11 webinars, but added 3 more in April, May, and June. So in total, we've had 176 attendees, and the webinar recording has been viewed 188 times. And I finally want to mention that AHRQ's Office of Communications has been really helpful in promoting the program at several conferences as well. So now the slide you've all been waiting for to see where we are. The next slide shows our enrollment to date. And actually this was of yesterday afternoon, so it's even higher than these numbers, but you can see that the number of eligible applications received was 428, with the number of committed practices being 259. And I can say that by yesterday afternoon, we had more committed practices and we're now over 300. So we're really excited about this, and we're still accepting some LOCs, letters of commitment, and processing some applications. So we expect there will be some changes in these numbers over the next couple of weeks. But as you can see, we've met that 300 to 500 range that we were seeking to meet. So I want to stop here. The next slide has some questions. We've got one prompted question for you here about the likelihood of practices being onboarded after the start date and strategies to ensure the newly onboarded sites catch up. But before we get to that question, why don't we take the slides down for just a moment and see what questions everybody has about what we've shared so far, if any. Okay, well, we can go to this question then. So those of you who've been involved in this before will probably have some insight in your past experiences, and those of you who are new can put your new eyes on this. But what strategies do you think will help us with newly onboarded sites who might come on a little bit later than the ones who are signed up to date in catching up while minimizing potential disruptions to the currently onboarded practices?
This is Jeff. I know with the AHRQ Mercer project, we had this quite a bit. And I've always focused on letting the practices know that they don't have to watch every webinar live. If they've already missed a couple, they can start watching the new ones and then catch the older ones on their own time, reviewing it and then sharing it that way. Also, just depending on how much data they have to submit, letting them know they can submit parts of it at a time just to get caught up. And really just working with the groups to let them know that, we want them to get this information. We want them, for this specific project, that, we want to improve antibiotic numbers. So our main focus is getting them caught up and helping them, not having them focus on, stressing about getting there, if that makes sense.
That's really helpful, Jeff. And what do you find it usually takes, how long it takes folks to kind of get caught up? Is it a few weeks or does it vary?
It's definitely depending, because there's groups. I have a couple groups in that project that are still just getting going, and they've gotten so far behind on their data that it's like, at this point, now let's get the data that's due and just make sure we focus on moving forward and getting everything. So there's some groups, unfortunately, that may not ever get all of the data, but for the most part, if you're a month behind or 2 months behind, let's say you could be caught up within a month or a couple weeks even.
Okay.
Depends on how busy they are on their main jobs as well.
Yeah, absolutely.
This is Padma, and I want to say that you all do a great job in, helping practices catch up at minimum disruption to currently onboarded practices by providing these webinars that they can provide, then providing the office hours where they can pair with newly onboarded, practices can pair with experienced ones. And if you could provide a detailed onboarding checklist, that would help them with the onboarding process, ensuring that they don't miss critical steps. And of course, having IAs check in on them and providing one-on-one technical assistance or implementation assistance, that helps them a lot.
That's great. Thank you, Pamela. Those are great suggestions. And Jeanette, I think you were hoping to speak too.
Thank you so much. I worked briefly on the MRSA project, but one of the things that I observed was not only the people jumping on board early, I wasn't part of that phase, but attrition. So new staff members being assigned and basically taking a good amount of time to familiarize them with the website, with the deadlines, and making that good time aside to be able to introduce them to the program to catch them up, actually led to get results for them, giving them the ability to jump in more quickly.
So I think you put a finer point on something, Jeanette, that it's not just people joining late, but sometimes the staff changing over in the course of it, and that requires an onboarding process as well. Yeah, do you find that happens more at the beginning or just throughout?
Jeff will be able to answer better, since he was working on that project for a longer period of time. But during the time that I was in, probably 3 months, I did observe quite a bit of attrition. So I did have to assist a lot of people kind of like get, basically land and run.
This is Jeff again. So I don't think it really was specific to the portion of the project as much as the cohort, like the long-term care cohort, unfortunately, just realistically has a bunch of turnover anyway. So we see it more with that cohort than the other cohort, in my opinion. And the biggest thing to help with that is just, having good notes and having a good, syllabus of everything you've been doing so that person steps in and isn't totally overwhelmed.
That's great. Thank you.
Yeah, I would agree with Jeff. The long-term care cohort is probably where we've seen the most attrition. So I'm really not sure in this setting what it will be like. I guess we'll find out soon.
Right.
I also say, as far as like catching up, I think it's going to depend. We don't understand yet exactly what the data collection is going to look like. And I think it's going to, once we understand that a little bit better, I think we'll be able to maybe even answer this question better. I know sometimes if that's not nailed down, like in the beginning, how the data is going to be collected, or we're not ready, and then we got to catch up later, that's kind of difficult if they have to catch up a whole bunch of data at a time. So yeah, I like the idea about a checklist. What I've done is similar. I always end our calls and then I send out, after I talk with the site, I will send out notes from our call, and it's always got a next steps, with what they're supposed to do. And that's always been super helpful. So it's real clear what's due when.
That's great. Thank you. Other thoughts about best practices for dealing with catching up the sites that may be coming out a bit later? And Priscilla, I see you have your mic open.
Yeah, Tanya, I'm not going to share the best practice because I feel like our IAs know this, a whole lot better, and we sort of appreciate all of the, practical ideas and guidance. I mean, I think just a couple of things. We have definitely collected information on more than one points of contact, as we typically do. That's not to say it's going to be perfect, so something, I think you'll let us know if it's working or not. We are thinking about, a list of like some key questions and things like that, that we are hoping you can help us gather some more information on as we, as you make your like sort of first engagement with the sites. I know, I think Padma, you brought up like sort of this onboarding checklist, so I think we have some ideas here, but always, interested in getting some more inputs on that. Kali, just something that I'm getting from the MRSA project. So, and I want to make sure we do it better on this project. I know on MRSA, we did have the situation where as practices came on, we had to send them, not practices, like in that, in our case, surgical service units or long-term care came on, we had to send them, piecemeal. So we are trying to think a little more carefully about how, for sites that are joining a little later, how we assign them, and we're trying to make that as painless as possible. Again, may not be perfect. So, interested if you have some perspectives on that as well. Okay. And Kali, I hope I'm not getting ahead of myself, but I know we've talked about it a little internally. Okay.
No, you're
So
not.
just keep me straight. Okay.
Were you asking the question about perspectives of the IAs or of me?
Oh, of the IAs.
Yeah, okay,
But
good.
you can share any perspectives you have as well. Okay.
No, I'd
We're all
like
a
to
team here. Yeah.
No, I'd like to hear the IA's perspectives.
Perhaps an additional, not a catch-up meeting, yeah, a catch-up meeting rather than your office hours, something similar, but just for these new recruited staff also might help, just for them to be comfortable around other similar organizations who are all onboarding late, to just ask their questions and they have time to ask their questions. So maybe an additional office hours just for the new or later recruited facilities. I think that helps for them to just spend the entire time asking their questions, which might be repetitive for people who have joined in the past and attended the previous office hours.
So you're talking about a dedicated office hours at sort of certain intervals in those first few months that are for people who are newer
Yeah, I mean like a catch-up hour rather than an office hour.
Catch-up hour, yeah.
Yeah.
Other thoughts on what Priscilla was sharing? And Jeff, I see you have your mic open.
I was really just agreeing. I love the idea Madhu had. I hope I said your name wrong, right? I apologize if I didn't. But so when I get turnover or new groups like that, I often do an additional welcome call for those groups. And if there's enough new ones available, having an extra onboarding call, I think could really save us time and maybe the groups as well. And they can be know there's more people like them that are in the same place and they're not, so far behind everybody. So just really agreeing.
That's a great suggestion. Thank you.
Carly, I have a suggestion. This is Padma to what Prashila said. And even when we are onboarding the new site, it's very important that we not only have the physician champion on it, but also the IT people, because there's usually a disconnect. And that's where we find that the champions come and attend all these onboarding meetings. They are unable to translate what they need in terms of data from the IT people. The IT people do not understand that this is a priority because they get a list of queries or reports and they, prioritize it and don't understand it. So right in the beginning, if you could have both the people who will be running reports or data submission, they and these medical champions, they work together so they can have the reminders on the calendar that this is when the submission needs to happen. And if we address it right in the beginning rather than later when they are struggling to give the data, we'll be, better at collecting reports.
So you're suggesting, Padma, I might hear two suggestions in what you're saying. One is to make sure those folks are attending these initial sessions and making that outreach and making it clear they should be. And then that's the same issue as we bring people on who are joining a little bit later. Yeah, I'm hoping, and I think this will probably always be an issue, but because we've done so much direct outreach and already engaged many of the folks who do the data work and the process of recruitment this time, which is a bit different than prior cohorts, that maybe we'll be more sensitized to that from the beginning this time, but we'll keep an eye out for that because I'm sure that's a challenge with some of the organizations we haven't spoken directly to.
Yeah, I saw like when we were working with one hospital, the medical officer went for a vacation out and IT people did not do anything till she came back after 3 or 4 weeks. And then she lit a fire under them to submit the reports. So I don't want that to happen.
Yeah, absolutely. Yeah. What about the rest of Priscilla's question? She had asked, we're going to attempt to cluster as we're bringing the new people on and give them to you more in batches than piecemeal one by one. Are there suggestions that you have about the frequency of that? What would be useful or helpful to you? And then I'll let Priscilla weigh in.
Well, this is Christy. I think the batch idea is good. I just wouldn't want to want you to have to wait until you have enough for a batch because I'm just not sure it's like the sooner we can get them going, the better. And so I would worry if you're kind of waiting. I don't know how it's going to work, but if you have to wait a while to get a big batch, then some are going to be just wondering why we're not contacting them. You know what I mean?
Yeah, Christy, that's a good point. Like, we don't want people sign up and then like, oh, I'm here for the party and when does it start? Like, you know what I mean? So I think we have to be mindful of like some timing cadence and, what makes sense. So we keep things a little coordinated with you.
Maybe instead of waiting on a certain number to make a batch, it's just every Friday to either the new folks that have signed up and that's just the frequency that way.
Is that okay? So that would be like weekly.
So
Is that too much? It's okay.
I'll put that out to the IAs.
Okay.
There are IAs who have done this before and if that's overwhelming or not. So.
I think it would be helpful. It also depends on how many are onboarding. If it's just one or two, I hate for to be spending that much time and resources on doing that every Friday. But if you're getting 5 or so,
okay,
then it's just going to depend a little bit.
Okay, volume depend. I mean, the other thing, and again, I don't want to get too ahead of myself, but just picking up on some themes that Carly brought up, there's a lot of enthusiasm about this program. So I guess what I'm saying is it seems to us, at least coming out of the gate, we're going to have a pretty robust cohort. We are mindful of the fact that, there might be some attrition. Be interesting to see what we see on this particular project, because as Carly pointed out, we have done so much of legwork, to bring people on board. They fully understand what they're getting themselves into. They've looked at the data collection templates, and Heather and Roy and others have had several calls. So it's been a lot of, sort of transparency in what we're doing, topics we're covering, data we're looking at. So there might be more stickiness. People are coming on board fully understanding what they're saying. That's not for everyone. So I don't know. We'll have to see, like you say, it's our sense that maybe we'll have a higher retention given all of the legwork, but who knows? Anyway, so the point I was going to make is because we have such a, what I would call a robust set of people or groups that are interested in joining us, we'll have to see just how much, attrition we have and where we have replacements and what that means in terms of what we share with the IAs, in terms of frequency and volume is, we're doing some replacement if sites fall out and things like that. Okay. Yeah. So I guess just a comment on that.
So when you talk about replacements, this is something that I don't think that we've done that I'm aware of. So are you saying that you're like capping it at a certain amount and then there's some like waiting if something opens? Is that what I'm hearing?
Yeah, so Christy, some of the other IAs might be familiar with this. We do have a wait list concept, right? Yeah, we've always had a wait list, like even for long-term care. In fact, that's a place where we've always had what I would consider a more generous wait list, because I think you all pointed out, like in long-term care, we always anticipate initially this looked like an exciting idea. People join the program and then they realize, oh, maybe it's more than they signed up for. It's not what they signed up for. Somebody left, somebody closed, whatever the story might be. So yes, we always do that. We even did it for
I never realized that.
Yeah.
So
say it again.
I just never realized that.
Yeah. So maybe it was just so subtle in the background. Yeah, we do it. I mean, because I feel like the sentiment on the project has always been, for all the projects, if there are sites that have an interest and think they can benefit and we have room for them, we have to, it's good to bring them along. So that's sort of been the sentiment.
Well, thank you for all of these suggestions. And this has been really helpful in helping us think about how to get you going and launched in the best way and how to make these changes as we bring in replacements or people come on late. I'm going to turn it back to Allison. Oh, Madhu, did you have another suggestion?
Yeah, sorry, just a quick suggestion is for practices onboarded after deadline, to just warn them in advance, to give them that specific notice that we are recruiting in batches or we will onboard in batches. So they are aware that there is going to be a certain wait time, whether it's weekly, bi-weekly, however it goes forward, but to warn them in advance saying, we understand you're recruited as of 24th, but the onboarding starts on 6th, just to keep them aware about the timeline, and so that they're not upset about waiting until they're onboarded. That would help too.
That's great. We'll be sure to sensitize people to that in the messaging as we're bringing them on these increments.
Okay.
So we'll have a chance to talk about some more of this in the onboarding section too. So if you have other questions, keep those at the ready. But I'm now going to turn this over to Sarah Keller so that we can begin the next section. If we can advance the slides.
Great. Hello, everyone. Yeah, so these have all been great questions and great discussion so far. And like was said, we've been focusing on kind of pushing a lot of this information out to the sites, to the participating sites, as they go through the registration process. But we did want to get a little bit into the educational content and the associated tools so that you can answer questions about this as well. Let's next slide. So because this is a little bit of a longer project than some of the projects have been in the past, the list of planned webinars goes on to two slides. But if you kind of look at some of the topics, we're going to have sort of a project overview in June, so that if folks end up then signing up in June, they can sort of quickly get onboarded by just watching the June project overview, hopefully, and that certainly will help. And then we get a little bit into what antibiotic stewardship is, why it's important, and overview of antibiotics. And then really our approach here, for those of you who may have worked, a couple of you I heard worked on the ambulatory stewardship cohort. And so some of these topics are obviously a little bit similar, but really kind of focusing on communicating with patients and families, particularly in a telemedicine setting, where this is not, communication perhaps a little bit more difficult than in person. And then topics that are likely to that clinicians are likely to see over telemedicine: flu, RSV, COVID, acute cough, viral upper respiratory tract infections, etc. And so that'll take us kind of through the winter when a lot of these things are going to happen. And we're also going to talk about ear pain, sinusitis, pharyngitis, allergies, and then some other topics that are also important over telemedicine: UTIs, cellulitis, sexually transmitted infections, as there are some patients that may be more likely to present to telemedicine to have this treated than to be seen going into a clinic. And then sustaining stewardship, we're going to end with sustaining stewardship activities. So going forward to the next slide. And so, as has kind of occurred before, each of these topics kind of comes as a package. So obviously there's the webinar that people can watch live and will be recorded and posted onto the website. And there's also the PowerPoint slides and accompanying facilitator guides that people can also use and perhaps share with other members of their practice later, and that will also be posted onto the website. We have office hours available for each topic for additional Q&A. And then one thing that's a little bit different here, many of you may know, especially those of you who have worked in ambulatory care before, that the amount of contacts that patients are having with clinicians outside of scheduled visits has skyrocketed over the past couple of years and is a major source of frustration for a number of clinicians. And these include things like patient portal messages, but also with that have come kind of more phone calls and things. And so we are providing sample scripts for asynchronous interactions, i.e. like patient portal messages that practices can edit, that can help streamline some of these interactions and make it a little bit more efficient for them, as well as scripts for synchronous interactions, like when a patient calls, how would you actually implement a triage system for a patient calling with a particular complaint. We also have discussion guides, and we're going to review examples of all of these in a few moments for practices to review as a group during existing meetings or groups of practices, such as like individual clinicians and in a larger telemedicine organization, and then handouts that are available electronically for patients and families, and a version of an antibiotic commitment poster that we'll get into in a few slides as well. Yeah, so if we can go ahead to the next slide. And for those of you who have worked on any of the antibiotic use safety programs in the past, this will sound kind of familiar, but we do have a slightly different take on the 4 moments of antibiotic decision making as sort of like the framework that we're providing, for which a lot of the educational content is being delivered. And these are kind of 4 questions. Moments was sort of more for the acute care and long-term care, but really kind of 4 questions or 4 considerations that a clinician should use when seeing a patient with a condition that could potentially be an infection. Yeah, so if you kind of skip ahead. And so this is sort of what it looks like. So you will see this kind of on a lot of different, logos and things. And if we kind of skip to the next slide, I believe that's where the questions are. And so really, these are the 4 moments. So the first question, and this is something that our TEP is kind of really highlighted a lot, who is an appropriate candidate for telemedicine? Because clearly there are going to be a lot of patients who may be calling if it's a more of a brick and mortar type telemedicine practice, i.e. they see patients either in person or over telemedicine, and they're calling in. Is there how should we assess whether the patient calling in with these particular symptoms can potentially be seen over telemedicine, or whether they should just be seen in person, or potentially, even sent to the emergency department if it's seems more acute, or there's more concern that the patient could be experiencing something severe that needs to be treated immediately. And then this, for for practices that are virtual first, or virtual only, direct to consumer, etc. How can they use these screening protocols to kind of see whether this patient really should be seen at all over telemedicine? So we are building the tools to kind of really ask this question first, which is a little bit of a different take from some of the prior cohorts where the assumption was the patient's already there, kind of talking to the clinician. And then we get to, does my patient have signs or symptoms indicating an infection that may require antibiotics? And do we need a diagnostic test? So clearly diagnostic testing is a little bit more complicated in a patient who being seen over telemedicine. They're usually sitting at home. I've also done telemedicine appointments with people in cars, sitting in parking lots, at their places of employment, etc. And so if a diagnostic test is needed, it's a little bit more complicated. We can't just kind of do it there in the clinic. We need to send, we would typically need to send the patient somewhere. So kind of asking this particular question. And of course, the signs and symptoms will actually are going through some potential ways that you can use, actually looking for signs over telemedicine, doing kind of more of a telemedicine exam. And then moment 3 is if antibiotics are indicated, what is the narrowest, safest, and shortest regimen that I can prescribe? And then moment 4 is also very important. What symptomatic relief should I offer or prescribe to my patient? And what should I tell my patient about the expected course and the follow-up plan? And so this is sort of the framework that a lot of the material is built around. And we think that, when I first kind of started seeing a lot of telemedicine patients over during COVID, I will say that they kind of said, just go ahead and get started. And our practice still hasn't actually, I'm saying this like, my practice still hasn't actually built a lot of these things, such as assessment for appropriateness for telemedicine. And assessments for and how to actually do a telemedicine exam. And so educating people in some of these things might be kind of more value added. So that's kind of how we're framing a lot of this. And then if you kind of go ahead to the next slide, we can talk about some of these examples of some of these resources that are being provided to the practice, that are also being provided to the practices. And so here's kind of an example of a asynchronous patient portal message. So a patient may send a message over the patient portal saying that I am feeling badly. I've had these symptoms, and I think I have a sinus infection. Can you please give me an antibiotic? We all get many of these a day, unfortunately, or fortunately. And so, and it always takes a few moments to respond. And there is data showing actually that primary care clinicians in particular now have spend 300% more time on telemedicine, or sorry, patient portal interactions than they did prior to the pandemic. So having a templated response for some of these common infectious conditions could potentially help out a practice, especially if there is a way that either the clinician could kind of do this with a dot phrase very quickly, or if there is more of a triage system, perhaps the nurse or someone like that could sort of put in some of this information. So go ahead to the next slide. And these are all editable because obviously each practice is set up a little bit differently. And so we wanted to make it so that they could this was a sample, but they could edit it. Similarly, if there is a nurse triage system where the patient perhaps is calling on the phone, there would be some provided sample scripts that they could use. And then skipping ahead to the next slide, we also have some discussion guides that are really kind of focused on after the members of the practice have reviewed either the webinar or one pager or some of the content in the webinar, how are we going to put some of these approaches into place, and really kind of got intended as a way to get the practice talking about things like what triage protocol are we going to use, and how are we going to kind of make sure that everyone's on the same page about about what our first choice of an antibiotic is, in the kind of the typical patient. And then going ahead, next slide, and we have one-pager documents that are kind of intended for the clinicians to review quickly some of the information available. Science Site is really intended to just be a very quick, again, one-page overview of the information. And then on the next slide, then we also have some patient information that would be available to kind of send to the patient electronically after their visit, providing them some additional information, really focusing on kind of a little bit on some of the first 3 moments, but really kind of focusing on this 4th moment. Symptomatic relief, and what can they do to feel better, and expectations. When should I feel better, and when should I contact my healthcare provider again, or potentially even go to the emergency department? All right, and then kind of going ahead. And then we also have these commitment posters. Those of you who have done antibiotic stewardship, improving antibiotic use cohorts in the past may kind of recognize this concept. And this is based on some data that's about actually close to 10 years ago, 10 years old now, that kind of uses these as like a nudge. So these posters are intended to help patients understand what, antibiotic prescribing, and that we commit to only prescribing antibiotics when they will help you. But they're also intended to remind the clinician that they have made a promise that are committed to only prescribing antibiotics when they will help the individual patient. And so there's this little piece at the bottom that says signatures or pictures of your practice. That piece is actually kind of important, and this could be, printed out and put on the screen behind the wall behind the clinician. It could be put into place sort of at the login screen. We have it sort of formatted for both kind of up and down, and this more horizontal format that could be used as a screensaver. And might be worth kind of exploring with the practice how it would work for them based on how patients access this information. Because really the goal is for the patient to see it, but also the clinician to sign it and then see it somewhere in their practice as well. It's a little bit different than having a poster, on the exam room wall, then where both the patient and the clinician can see it together. And so some examples really are kind of at this time of login, as the patient's kind of in like a virtual waiting room, or even on the practice's even on the practice's website. Yeah, so, and then going ahead to the next slide. So this is, this was really intended as an extremely brief overview of the intended approach for education, as well as implementation of some of these tools. And so we first kind of wanted to pause and ask for any reflection or feedback or thoughts on any of these, and then we'll get into some of these questions. All right. So I guess if there's no initial feedback or thoughts or questions, we can start with this kind of first written out discussion question. Given this planned approach, what suggestions do folks have on educational implementation approaches that could optimize that can optimize this process?
Sorry, can I, Sarah Priscilla here? I want to just ask, like, in this question, I just want to make sure, like we asking our AAs exactly what we're looking for. Are you asking how the tools, which really look great, by the way, it's really nice to see what you and Pranita have put together, how they will get implemented, or on the materials themselves? Which one is it? I'm just trying to be clear.
Actually, let's kind of refresh a little bit.
Yeah.
Can we ask, actually, could you go back to the last slide with the commitment poster? Does anyone have any feedback on the commitment poster in particular? Since this is one of the tools that we think is going to be more widely used, or hoping is more widely used, and some specific questions about the is the message clear, general thoughts about it, and then thoughts potentially about how to implement it or where to implement it.
I noticed on this picture that they are both, they're saying the same thing just in different ways here. And I thought the one on the right, the wording's a little bigger and pops out better in my opinion. Because it took me a minute reading over them both to realize that they were the same thing, just in different orders, just for different looks. And if I were to look at a wall, I feel like it would be a better chance of me reading the big writing than the other one. The smaller one looks like a lot more writing, but it's really not. It's just the way it's portrayed.
Thanks. I have a suggestion for the second one, the one that he said that is easier to read, but what is in it for the patient? So you're saying we commit to only prescribing antibiotics when they will help you. They might think, okay, this practice might not help me. Do I go and shop for antibiotics somewhere else? So it may be more educating them, and antibiotics only fight infections caused by bacteria, the first sentence. Maybe that could be put in there, and then say, this is our commitment. I don't know. That's how I feel. Other IAs can chip in for that. Because if I'm a patient, I'm looking, what is it in it for me? But if I'm taking my kid there.
I sadly do agree that people are looking for medications when they go to the doctor. So how can we tell that story more accurately? Because as we know, just giving an antibiotic is not a good thing, especially if it's not needed. But I don't have the right answer for you, but I have a good question.
But that's
exactly, yeah.
Yeah, that's the logic that then you're educating them. Antibiotics only fight infections caused by bacteria.
Right.
So that's the answer. So now they know why they are not prescribing it.
I completely agree. I think when we're in the waiting room, the material we're looking at should be preparing us for the visit to ask the right questions, rather than making us feel like, okay, I'm going to bring this up and they're going to say no, rather than being heard. So I think rephrasing it, I completely agree with Padma and Jeff too. Something more in the sense of why the effects of antibiotics, the side effects, more about that, so they're prepared for their visit and educated about it as well while waiting. That makes more sense.
And loved your messages to the patients. That's really good. You could put some points out from there and put it here. The messaging was great.
Yeah, I was having the same reaction to speak to the patients more. Like, and I don't know, you've probably researched other posters and information that folks have used in various antibiotic stewardship campaigns, and maybe this is right, but something more along the lines as others have been saying about we want to help you feel better and sort out if antibiotics are needed or not. If they're not needed, they can hurt you. Yeah, it just seems like maybe some tweak it might be needed.
I have a raised hand. I just wanted to zoom in on something. I think that the big message is at the top, and it should be in bold: antibiotics only fight infections. And then be followed with, please, or if you want to discuss further with your provider, please take advantage of your appointment, or something to that effect, like discuss with your provider this information, right? Because I think that like telling them the antibiotics can also cause certain side effects may probably discourage patients who actually need antibiotics from taking them, from receiving them. So I would be a little concerned about, especially for individuals who have low literacy levels, or may not be, as versed with the medical world, that message may be received differently. So I think that I would highlight, the top, and then come up with the questions, let's discuss with your provider more information about antibiotics, something like that. Just leave it. I don't know. That's my take.
This is all really helpful feedback. Carly raised the question, would it be helpful to have versions that's virtual first versus brick and mortar type practices?
I was going to ask about the virtual option, because I know on some of these websites, you look at some of these virtual only organizations, they have like get your prescriptions now and like 24-hour access to prescriptions. So I don't know if that's like a push-pull with their marketing folks versus, what we're trying to accomplish here, but I do think there's something important or an opportunity for the virtual folks to also have access to these, whether it's a website banner or if it's something that's on hold on the web page, like, when you're waiting to log in to your virtual appointment, there's kind of just like maybe that's something that could go there. I think there's different options.
Yeah, some virtual first practices, the ones that are interested in antibiotic stewardship, are starting to put some of this, like not quite this phrasing, but some phrasing kind of as you click on a button that says sinusitis, it'll say something. So there are some of those options. It's interesting. There's a lot of data that say that people don't actually want antibiotics. Clinicians think they want antibiotics. They want patients want doctors to listen to them. As a theme that we are trying to get across to the clinicians on the who are participating in this project.
Got it. Thank you.
Would it help to have a poster more like the practice is participating or in this program, just to explain to them that the practice, it kind of sends the same message, right? They're participating in a antibiotic safety program, which kind of sends the message that they are committed towards safe prescribing of antibiotics. So that might be a good poster to have as well.
These are really great comments. Any other comments?
I was just thinking back to the general question about how to optimize the process or the educational approach, is just make sure we're hitting upfront the big barriers that they're facing. And I'm kind of assuming you've done that as you've mapped out the different education sessions, but are they each addressing the barriers that we know these folks are facing? And I don't know if there's a right order to do that in, if they all facing similar big barriers, kind of hit those early and upfront. Yeah, just a thought.
This is helpful. And as kind of a sort of a follow-up add-on question, are there any educational or implementation approaches that we should make some that should differ, or that we should between the virtual first and brick and mortar type practices?
Maybe a little oversimplistic, but providing information on what is bad bacteria. Not everyone, I mean, we're very familiar with the term, but shall we assume that everyone knows and that's why they can only get antibiotics when there is a bacterial infection? I don't know. I'm just thinking from the more uneducated, community's perspective. Just a thought.
Okay. And kind of similarly, are there, do you anticipate practices will require additional support for any specific interventions or modules? And we can go back to either the slides listing the modules or the slides listing the tools.
Sarah, I have to compliment you. You have put such a thorough, robust plan, educational plan for them that we really cannot make, I cannot think of any suggestions to offer. It's a very well thought out educational resources that you're providing them. And that's why we can't make, at least I can't make any more recommendations or suggestions.
Thank you.
I'm just thinking about from the health equity. If you're thinking about that in different cultures or whatever, some of the scripting, does it have to change? Do you need to kind of look at that? Just wondering if that was, if you gave any thought to that.
Yeah, so we try to make things flexible, knowing that each organization, especially if they operate in, more brick and mortar or in a particular location, that they may need to put in additional things. And like in the South, they might want to say something about BC powder because it's going to come up in some of these conversations. Or we do not have that where I practice currently. So we were trying to encourage, I guess what I would, trying to encourage the practices to be, see these as resources that they can modify to suit the needs of their particular patient population, I guess would be the approach that we are taking. Without trying to overwhelm folks, knowing that there are thousands of iterations of how practices are organized and etc.
I would just also encourage, like when you're developing the content for the like the webinars, that if there is data that kind of point to a certain, again, the whole health equity thing, that the practices are aware of, where they might have to think a little bit twice, based on what their population is.
Mm-hmm. Yeah, definitely. Okay. Anyone with any last comments? All right, if so, I might hand it back over to an RC.
Thanks, Sarah. Okay. So it's 12:25 Eastern time right now, and I think we're scheduled and ready for our what would be lunch break. So I'm gonna say that let's take a break now and plan to come back at 1:30 Eastern time. So just about an hour from now. And we'll meet back here, and then Carly will talk a little bit about the rules of the IAs when we come back.